assigned a scenario involving complications with a deep vein thrombosis and a partial pressure carbon dioxide level below normal ranges. The current level is 30 millimeters of mercury. An auscultation and percussion assessment have been performed of the thorax and the abdomen. The assessment has indicated a region that is filled with fluid in place of air. The main concept of pulmonary disorders we're dealing with is a vascular disorder, and the disruption of systemic functioning is a pulmonary embolism.
Pulmonary embolisms occur as a result of a deep vein thrombosis, which is when the patient has a clot, typically in their leg. This clot then travels upwards into the lung and restricts blood flow. This can cause ischemic injury to portions of the lung. The low PCO2 level is another indicator of a pulmonary embolism. This is caused by the patient hyperventilating due to rapid breathing, which causes those CO2 levels to drop. Their level is below 30, which indicates a respiratory alkalosis. This patient would also be hypoxic due to lack of O2 in the blood. The consolidation you hear upon assessment would indicate fluid in the lungs, which is also indicative of a pulmonary embolism.
Any disease under the vascular disease category has to do with disrupted blood flow through the lungs. Since there was oscillation and percussion indicating consolidation, it led to look into the following diseases further as potential diagnoses, but then were later dismissed. Pulmonary artery hypertension is defined as a pressure greater than 25 mmHg at rest, which matched or given 30 mmHg. This disease has several different groups under it, including COPD. It can be characterized by endothelial damage or overproduction of vasoconstrictors or decreased production of vasodilators. This could cause the consolidation that we saw. However, we did not choose this one because there was a lack of a complication from a DVT. However, if you are unaware of this DVT, the similarities could be confused with pulmonary embolism. Pleural effusions and pulmonary edema were also considered. Pleural effusions is a complication where there is a presence of fluid in the pleural space. Pulmonary edema is typically caused by heart disease and is manifested with excess fluid in the lungs. The main reason these diseases were also considered were because of the consolidation. Fluid in the lungs could cause both of these diseases to have that. These diseases were then later dismissed because neither could be caused by a DVT, nor could we conclude that the disease was caused by
Pulmonary embolism begins with Virchow's triad, which is a risk factor that occurs prior to pulmonary embolism, which then leads into the DVT, as you see here. So starts here, that moves into the deep venous thrombi, which is largely preventable if it hits this.
If the thrombus becomes an embolus and travels to the lungs, the body may exhibit respiratory alkalosis, during which hydrogen and bicarbonate are being converted into water and CO2 very quickly and releasing those products in excess via hyperventilation.
Due to an increase in pH and low hydrogen, the cell will donate hydrogen ions to the bloodstream and take potassium ions from the cell to maintain resting membrane potential, causing hypokalemia.
So here we have the cellular mechanisms of a pulmonary embolism, and there are 4 different results that can come from a PE. Starting with infarction, this is going to be bleeding in your lungs, so it will result in sudden death. There's no symptoms prior to it because it comes on so fast. Next is without infarction. Bronchial circulation, this is basically your body protecting you from an infarction. It's going to increase that perfusion to fight against that blood clot. Next is massive occlusion. This is blocking a large portion of circulation, which can also lead to death if it's bad enough, and cardiac and pulmonary failure. Last is multiple pulmonary emboli. This is going to be chronic and reoccurring, so a patient is going to be coming back and trying to get these treated. They could have multiple, just a reoccurring PE. And lastly, all 4 of these can lead to obstruction, which can later lead to more issues down the road.
Clinical manifestations of a pulmonary embolism, it's important to note that the signs and symptoms are dependent on the size and the placement of the embolism. Some generalized signs and symptoms include pleuritic chest pain, dyspnea, tachypnea, tachycardia, unexplained anxiety, syncope, and hemoptysis. Also, the APG analysis will show hypoxemia and respiratory alkalosis, leading to hyperventilation. The clinical manifestations for PEs are nonspecific, and DVTs are often asymptomatic. When making a diagnosis for pulmonary embolism, it's important to consider risk factors, particularly those relating to venous stasis in the Virchow's triad, and also genetic predisposing risk factors.